All right, good morning. Good. Make sure I have my pointer. So for some reason, Dr. Center thinks that I'm a morning person, maybe because I'm a surgeon, because I always seem to get the 8 a.m. lecture. So next time I'm putting in for 2 p.m. because everybody's sleepy, but I'll try to wake you up. And then Dr. Feely will really wake you up. So my task, along with Dr. Feely, is kind of indoctrinate you into common knee problems and how to triage them in your practice. So I'm going to talk about the top 5. There's a couple more that you may see on occasion, but these are the much more common injuries that you're going to see and try to sort out and figure out, do they need to be referred? Do I need an MRI? Do I just need to send these people to PT? Because that's what our ultimate goal is. So why pay attention? You're going to see a lot of musculoskeletal problems in your practice, as you know, significant amount. And unfortunately, in our medical schools still, and oftentimes in residency, it's a kind of an underserved community in terms of your teaching and indoctrination into MSK problems. You may learn more about what's going on in that slide, which I could say I know something about, but I don't. No, just kidding. Versus knowing how to sort out a knee problem. So that's why we're covering this, and that's why you're here today. Hopefully by the end of this talk, you'll know what the significance of that slide is and why you should probably send it to us to get evaluated. So, because that's your mystery thing right now. We're going to go over common symptoms in the different knee problems, imaging modalities, what to do and what not to do. MRI is not always the most appropriate thing. And so these are the more common problems that we see. MCL, ACL, patellofemoral pain, meniscus problems, and then cartilage injury. I'm going to go through some of these this morning. Again, this is a reiteration. Dr. Feely is going to specifically talk about the subset of arthritis in his talk because there's a lot of good data out there on treatment modalities, and so he's going to cover that extensively in his talk, so I'm not going to really delve into that as much. This is kind of redundant. Okay, so let's get to the case, the ARS number 1, 56-year-old male with a 7-month history of moderate knee pain, gradually worsening and described as achy. He had meniscus surgery 4 years ago, which helped for a while. He used to run. Now mainly he bikes and swims, and his pain is medial near the joint line. He says his knee sometimes swells. What's his most likely diagnosis? Just pick in your numbers. All right. Good. Okay, we're done. Everybody can go home now. You, of course, can have a meniscus tear with osteoarthritis, but given the patient's age and the achiness, fact that he had meniscus surgery years ago, more likely to be arthritis. And it's a big problem. It's going to be a big problem in your practice. I was kind of astounded when I was looking at these numbers that 33% of adults have arthritis, and more predominant in women, which is interesting, and obviously the prevalence increases as people get older. One of the things to think about in your practice, and Dr. Feely is going to go over this a lot more in detail in his talk, order weight-bearing x-rays before you order an MRI. There's so many people that come in with an MRI that shows that a patient has a meniscus tear and they have full-blown cartilage loss on the medial compartment, and an x-ray would have shown bone on bone in the medial compartment. And that's a completely different triage from seeing a sports specialist versus maybe seeing arthroplasty or getting an unloader brace, something like that. So, all right, so case 1.5, it's in between this and the next topic. Another ARS question. 24-year-old male with a 2-month history of knee pain and swelling after a fall off his bike. He landed directly on his knee, and since that time, he has pain and swelling and occasional mechanical symptoms such as clicking or locking. He has achiness over the medial femoral condyle. What's his most likely diagnosis? I always feel like I should do the Jeopardy song during this. Do, 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 do. Except I don't want to do that this early. All right. Meniscus tear, okay, good. So I have some teaching to do in this topic. Okay, good. All right, so this is a chondral or osteochondral injury most likely. Because he fell off his bike, it was a direct blow to the knee as opposed to a twisting injury, which is usually the cause of a meniscus tear. It also can be caused by overuse and progressive wear, but the patient's 24, so that's less likely. He might have a cartilage flap that's loose and causing catching, may even have a loose body floating around in his knee. And oftentimes, especially in this younger age group, we may need to do surgery to treat his pain and mechanical symptoms. This is an example of one of my patients, an extreme example. This patient has a loose cartilage flap here. It's kind of delaminated from the rest of the bone, and a lot of bone edema underneath it, which means his knee is very distressed and unhappy. The meniscus has a little bit of signal in it, but there's no obvious tear. But you can see that's delaminated. This is what it looks like inside when the cartilage flap has come off and the bone is exposed underneath, or this. This is almost too perfect. It's a perfect circle, but it really was what the patient lost cartilage here, and then the surrounding articular cartilage is normal. So how do we treat these? Younger patients with smaller amounts of cartilage loss, 1 to 1.5 centimeters squared, oftentimes do better with surgical treatment. And the treatment that we do depends on how big the defect is. There's a lot of new cartilage repair techniques constantly evolving, getting FDA approval, going through clinical trials right now. So it's pretty exciting, actually, area of research for us at UCSF. Unfortunately, a lot of times in patients over 40, it seems to be the cutoff that a lot of these cartilage repair procedures don't work as well. And I have lots of people that come in with diffuse cartilage wear, which i.e. is arthritis, and they want to do stem cells, and they want to do one of these cartilage repair type procedures, and they just don't work as well. Or they've already had the procedure by someone who didn't share with them that the results aren't as good when you're over 40. So a lot of times in patients that are older, we consider doing an unloader brace that unloads whatever side the cartilage loss is on. And you can do this also for full-blown arthritis. And non-surgical treatments, because patients don't respond as well to the repair techniques that work well on younger patients. So some of the more common procedures that you may have heard about, microfracture is probably the original type of cartilage treatment that people started using. Basically, you poke holes into the subchondral bone, and then the subchondral stem cells differentiate and create fibrocartilage, which covers over the exposed bone. And it works well. The cartilage that fills in is almost, I always say it's like shag carpet. It's a little softer and not as durable as normal cartilage. Normal articular cartilage almost feels like linoleum when you touch it arthroscopically, whereas the fibrocartilage that fills in from microfracture oftentimes is a little bit softer and spongier. So it's not as durable, but it's better than having exposed bone. So we tend to do this for larger defects, but again, it doesn't respond and do as well in older patients, which is why we don't do it on someone that's 55 that maybe has alignment issues or is bow-legged, because it's just not going to fill in. One of the other options that we do more commonly is something called a mosaicplasty or osteochondral allograft, where if the area is a small area, we can take a cartilage plug from somewhere else in the knee that there's not as much contact, oftentimes up at the top called the trochlea area, and we can use it to fill in a defined defect. And you notice this patient almost had a perfect circular area of cartilage loss, so she was a good candidate for this osteochondral allograft. There's a piece of bone and then a cartilage cap that we took from somewhere else in the knee. Obviously, you can't rob one area of the knee too many times to fill in another area, so this is good for a smaller area. Now, there are newer techniques that are coming out where you can harvest cells and reimplant them, and there's a lot of development in this area. One of the biggest issues with harvesting cells and growing them in culture and then putting them back in is that you may grow cells, but they don't have the same architecture and biomechanical properties as your own articular cartilage. It's just a bunch of cells. So there's a lot of research into like, how do we teach these cells to grow in the right pattern so that they can hold up against shear stress and compression stress and have the right fluid fill in them to make them mature cartilage layers. So that's the challenge for us research-wise. Okay, so moving on, because I have a lot of topics for you. Next ARS question, a 35-year-old basketball player makes a rapid pivot on his fixed leg and feels a tearing sensation in his knee. Tries to keep playing, but has a moderate amount of discomfort along the medial joint line. His knee swells a moderate amount over the next few days. He notes pain along the joint line with squatting and climbing up downstairs. Most likely diagnosis is good, meniscus tear. So you notice this one's a kind of twisting type of mechanism, much more common or much more likely to be meniscus tear than the first injury, which was more of a impact type of mechanism. So meniscus tear's most common mechanism is rotation of the femur on the tibia, i.e. twisting the knee. Sometimes it can be repetitive squatting that can trigger a meniscus tear also. Clinically, a patient oftentimes has pain along the joint line, not in the front. I would say pain in the front of the knee is patellofemoral, which we'll get to later until proven otherwise. They may have giving way due to pain, clicking sometimes, small effusions, and locking of the joint sometimes can occur. That is more common with a specific type of meniscus tear that I will show you. There's lots of different types of meniscus tears. So I'm not going to go into the morphology of meniscus tears. Some of them are more likely to cause pain than others, especially ones that have a tear like this or a flap that folds under, because when you twist and bend, it pulls on that fragment, and then you have joint line tenderness. Classically, when someone has a meniscus tear, they're usually able to continue their activities. They may note a certain time event where the pain started. They don't usually have pain or swelling within a few hours, like some other types of injuries. They develop it overnight. So the next day after they injure themselves, they oftentimes wake up with a very stiff, swollen knee, discomfort with activity, squatting, twisting, joint line tenderness. And oftentimes patients are able, and especially in these flap tear type situations, are able to pinpoint exactly where their pain is. So we have a bunch of evaluations. I call it the 5-point test, and we're going to get into this a little bit more when I do the patient demonstration in the next module, if you want to call it. But I kind of use the 4 out of 5 test when I'm trying to decide whether to order an MRI. And I think it's a good practice. I teach it to the residents and the fellows. You know, if the patient doesn't have 4 out of 5 meniscus signs, then I don't order an MRI. And we always get x-rays first, especially for patients that are over like 40. They have to have joint line tenderness, again, like mid-medial, posteromedial, or mid-lateral, posterolateral. A Thessaly test that's positive. Pain going down or rising up from a deep squat, again, not in the front of the knee. Pain with a duck walk or a positive McMurray's test. So, Buster is demonstrating part of a duck walk or a deep squat. This is joint line tenderness. Again, get x-rays beforehand. So joint line tenderness, you want to palpate. Most meniscal tear tenderness is mid-joint line or back here. Again, not in the front. I don't consider that to be positive for meniscal pathology. Thessaly's test, I finally got around to making a video, but basically you have the patient stand on their leg, bend it just a little bit, and rotate like this model's doing. Or this is my scribe demonstrating a perfect Thessaly's test. So she's rotating. If patients have like horrible balance and cannot do this to save their lives, you can ask them, do you have pain getting in and out of the car? Because you have to almost plant your leg and then turn to get into the car. So you can kind of think of creative ways to reproduce this test. And oftentimes patients will say, oh yeah, I have pain like getting in and out of the passenger seat or the driver's seat. So, and then lastly, a duck walk basically is doing a squat and then kind of walking across the floor. So it's kind of like an active squat test. McMurray's test is, a lot of these tests are all designed for flexion, deflection of the knee, compression and rotation, basically to compress the meniscus and pull on the tear and reproduce the patient's symptoms. So this is the bad picture of a McMurray's that you would never know how to do the test, so I made a video torturing one of our athletic trainers. You notice I'm kind of swinging the knee in and out and also rotating at the same time. And we'll do this again in the next session, but just, multiple exposures make you remember, so doing it multiple times. And this is the only sweater I have, in case you're wondering. All right. Carlin and I conspired to wear Duke blue, but even though she didn't go to Duke, she went to UCLA. All right, so imaging, when you get to the 4 out of 5 and you order that MRI, a normal meniscus is jet black and doesn't have any white lines going through it, like in this picture. There's a lot of different tear patterns. You can have an oblique tear that goes this way. You can have a vertical tear that goes up and down. The tear pattern oftentimes will suggest how we're going to treat something. And whether it can be repaired versus trimmed. This is an oblique tear, as we mentioned. One of the reasons why this sometimes can cause a lot of symptoms is this bottom flap, when the patient twists, can fold underneath, and then it kind of sits along the side of the bone on the tibia and causes a lot of discomfort. Patient will complain that they have pain when they have their knees together, when they're sleeping. It's a common complaint with these flap tears. And this, if it folds underneath, if you notice this, there's a meniscal fragment right here, right next to the tibia, right underneath the medial collateral ligament, can cause a lot of symptoms. These patients oftentimes come in, they're like, I want surgery now, because it's very irritating where the fragment is. Right there. All right, so treatment options for a meniscus tear kind of depends on chronicity and also age of patient. An acute tear, younger active person, oftentimes we go straight to recommending surgery. Sometimes they're chronic types of tears. It depends on the activity level of the patient, which treatment modality we may go to first. An active older person, we may try physical therapy first and then refer for surgical evaluation. A lot of times this is kind of 60-ish year old, I'm getting close to that, it's kind of making me nervous. 60-ish year old, we may do PT, activity modification, and I also need to add on, consider steroid injection. Sedentary, older person, maybe has arthritis, definitely PT, activity modification, steroid injection. If the cartilage is in good shape, this patient may fail this, and maybe then we should consider surgical intervention for a tear. Surgery is not without negative consequences sometimes, and that's sometimes what we forget. Everybody's like, oh, I just need, do a knee scope. Everybody does fine with a knee scope, right? If a patient is older, and like plus 50 plus, and especially if they're a little bit overweight, there's a complication of arthroscopic surgery which can happen. It's called post-op osteonecrosis. And it's no joke. If someone develops SONC, that's what we call it, they can get osteonecrosis, which sounds horrible and is pretty bad. The bone dies inexplicably above where the meniscus tear was in the femur, and people get horrific pain. And I always say they take the short track to needing a knee replacement, and just from a simple knee scope. So I have to be very careful with just recommending doing an arthroscopy on an older patient, especially if they're a little bit older and heavier, because it's not without that bad potential consequence. So it's not always, an arthroscopy is not always a super benign procedure. Youngsters bounce back from it with no problem, but it can have some really negative consequences in an older patient. Okay, so meniscus tear treatment, if we get to the point where we recommend surgery, if they have mechanical symptoms and it doesn't respond to physical therapy in an older patient, we may trim the meniscus, especially something like this where there was a flap that was folded under the meniscus, and we trim that out. Debridement is not fixing or repairing, it's trimming, versus repair is with suture, two different physical therapy protocols. So we repair when the tear is out to the periphery where the blood supply is less and the patient has a good potential for healing the meniscus. We trim if it's an inner tear or flap tear that doesn't have a good blood supply. And it's a little bit of a judgment call on my part or my colleague's part in terms of which way we go. Obviously, a younger patient is going to have more likelihood of healing a repair. An older person, we may need to trim, but we don't want to take the whole meniscus out either. So they either get repaired or trimmed. And again, older patients oftentimes go PT and injections as first-line treatment. Two things you don't want to miss that you want to refer right away. Bucket handle tears and root tears. Bucket handle tears, oftentimes patient presents, they were squatting, and all of a sudden they're knee locked and they couldn't straighten it out all the way. That's like the classic thing. Not a few hours later, because sometimes the MCL tears can stiffen up patients. It's like an immediate, I couldn't straighten my knee out. This is a bucket handle tear. Oftentimes we call it the double PCL sign, where the meniscus is torn from the back and then flips over into the notch here, this fragment. The easier way to tell it is on the coronal views that go through the knee this way, that there's a big fragment of meniscus in the notch, which you would not normally see. Or sometimes it'll look like there's like a tiny meniscus in the back on these sagittal side views of the knee, and there's a big fragment in the front. The other one is a root tear, which is actually more commonly just recognized in the past 10 years as a bad customer. The meniscus is torn off the bone attachment in the back. And you see this little gap here on the coronal views. If the meniscus loses its bony attachment, especially on the medial side, it loses the biomechanics get all messed up, and the knee almost acts like there's no meniscus there because the meniscus can extrude when the patient weight bears. So this is a bad customer and can lead, if it's neglected, can lead to rapid degeneration of the knee and the cartilage, because it's almost like the person had a complete meniscectomy, even though the meniscus is there. So you don't want to miss these root tears. If you notice the lateral meniscus that covers the whole surface, looks kind of jet black and healthy, and then it goes all the way over to where the root attachment is here. Whereas this meniscus, there's a gap, and then there's the attachment to the bone. So if you see that on a report, you want to refer. Sometimes patients that are older can have this, and they may not do surgery anyway, because if their cartilage is really degenerative and they have arthritis in the knee and they have a root tear, there's not much we can do. But if it's a younger patient, good cartilage, we want to try to fix these acutely. So these are the red flags. Dr. Feely's kind of came up with this, but locked knee, patients often comes up from a deep squat, and the meniscus flips in the front, usually a younger patient. The patient may have chronic knee instability or chronic ACL tear that's led to it because they've had giving way episodes. The meniscus has developed a tear in the back. And one day they squat down to pick up their little kid. That's like the classic thing that people sometimes present with. And the meniscus flips in the front and they acutely can't straighten out their knee. And they'll oftentimes come in on crutches. Sometimes they'll present to the emergency room. So think about that. Patient rising up from a deep squat is the most common mechanism that makes it flip. This is a picture of the meniscus flipped in the front of the medial femoral condyle. I have to push that back, and then, I don't know if you can see that we can repair it. There's repair sutures here. And these oftentimes heal because they have a great blood supply. The tear is very peripheral. But you want to put patient on crutches if you suspect this, get an MRI, or just refer them immediately and we can get the MRI. But tell them to get on crutches and not walk around on it. If they walk around on it for 6 weeks or 8 weeks, and they may make it unrepairable. And then they have no meniscus in the knee. Root tears, again, this gap between the meniscus and its attachment to the bone. You may not recognize this. There's a lot of orthopedic surgeons that miss this, but if you see that on a report, you want to refer. That's the big thing. It's a difficult problem in older patients when they get this, but it can also happen in young patients with an acute ACL tear. But you want to put the patient on crutches, refer them, let us decide whether we need to fix it or what we're going to do with the patient. All right, number 3, 41-year-old, 210-pound male, complaining of bilateral knee pain, left greater than right. He has anterior knee pain with stair climbing, long walks, and after sitting for long periods. Sometimes his legs feel weak, as if they might give out on him when he's walking down the stairs. He has faint swelling on occasion. The most likely diagnosis is yay, good. PT. We can move on to the next thing. You want to do physical therapy, that's the most common thing. So patellofemoral pain, anterior knee pain. So this is the one where patients have pain in the front, Oftentimes we have the positive theater sign where they're sitting for a lengthy period of time in the theater, and then they go to stand up, and the first few steps are kind of miserable, and then they're like, okay, because they have cartilage wear and inflammation in the front of the knee because of it. Oftentimes pain going downstairs or hills can be associated with increased activity. They get swelling and pain. They may feel that they have instability, but it's a giving way forward type of instability as opposed to ligament instability, which is more of a side-to-side type of instability. And there's no specific injury mechanism or traumatic injury. Patient may have normal body habitus. They may be overweight, which definitely puts more stress on the patellofemoral cartilage. They may have some ligament laxity, but not torn ligaments. They have pain with a deep squat. They may have some quad atrophy. They oftentimes have very poor core stability, as demonstrated by this patient. And for some reason it's not. Can we run it one more time? This is a single leg squat. It's a really good test it's also for balance too, but just seeing how weak someone is. The knee collapses into valgus, very shaky. So these are things that can be improved upon in physical therapy and oftentimes will help patients with patellofemoral pain. So here's Christina again with her excellent single leg squat and my test patient who's faking shakiness. Can we do the one on the right? Yeah. So she does yoga and sports and has a perfect single leg squat. That's a perfect on the right. She could use some work on the right. So. All right, so there's modifiable and non-modifiable risk factors for patellofemoral pain. We can't fix someone's foot pronation other than having them wear better shoes, which a lot of times teenagers walk around with Uggs and Vans and Chuck Taylors, and they have pronated feet, and sometimes you can help them get better, have less patellofemoral pain, the young gals, by just telling them to wear inserts in their shoes like Superfeet. We can't do anything about the shape of the kneecap joint, of the patellofemoral joint. We can't really do anything about someone having a valgus alignment, but we can do something about dynamically controlling that valgus tendency by having them work on core stability and glute strength, which was what was demonstrated by the single leg squat. People can lose weight, that can be helped. Obviously, physical therapy is a big component on this and working on core stability and flexibility. So, should we do x-rays when someone comes in with patellofemoral pain? It's not always that helpful unless someone has really advanced wear. I only order an MRI for when someone presents with patellofemoral pain when they have failed physical therapy because there's not a lot of great surgical options for treating patellofemoral pain. It's really a rehab type of thing, an activity modification type of modality. So there's two ways to image the patellofemoral joint. A sunrise view, which is what's done in the emergency room where you flex the patient's knee up like 80 and 90 degrees, forces the kneecap into the trochlea, makes the joint spaces where the cartilage is look great. This is the same patient with what we call a merchant view, which is about 40 degrees of flexion. Same patient. This looks completely normal. This one, as you can see, is bone-on-bone cartilage wear, lateral subluxation of the patella. So it's pretty striking. You would never know. But that's why we get a merchant view, 40 degrees of flexion, looking at the patellofemoral joint. Then sometimes we have to get an MRI, just basically shows cartilage wear, but there's not a lot of things we can do. Those cartilage repair techniques don't really work well for the patellofemoral joint at this point in time, unfortunately. So it's always about physical therapy, and there's studies that do show that it's helpful. What do you write when you send someone for anterior knee pain? You don't think it's anything that's surgical. Work on range of motion, especially core stability. Glute strength is a big component. A lot of people are horribly, and you can do that single leg squat test and have a laugh in clinic and see, you should try it yourselves. It's sometimes quite hard. You can check that on the patient to show them, yes, you do need physical therapy. Look at, your single leg squat is not that good. And they can assist, the physical therapist can assist with return to sports for the patient. Okay, case number 4. 20-year-old soccer player attempts to avoid an oncoming defender by making a rapid cut and change in direction. As she pivots, she feels a loud pop in her knee. She tries to keep playing but has a moderate amount of discomfort, and her knee gives out on her the next time she tries to pivot. The knee swells up a great amount in the next few hours. Most likely diagnosis is... Yay, good job. Okay. All right, ACL tear, near and dear to my heart. Just an example, MRIs. ACL is a very vulnerable looking structure, I always say. It always looks like a rubber band going between the tibia and the femur. Most commonly, when it tears off the femur, scars down to the posterior cruciate ligament. There are other ways that it can tear. Sometimes it can avulse off the bone in pediatric patients, but this is the most common mechanism. One of the reasons why there's research looking into trying to do ACL repairs again with some sort of fibrin clot type of sheath to do the repair is that ACLs tear off the femur, and if we can reattach them to the bone, that might be successful. So there's a lot of research looking into that. Oftentimes, the ACL injury is a non-contact injury with a twisting. Someone plants the foot, goes to change direction, knee drops into valgus, and patients feel a pop in their knee 70% of the time. Oftentimes, swelling within a couple hours because there's a hemarthrosis from tearing the small artery that goes to the ACL. Not always, but most of the time. Patient may try to return to play acutely, but then the knee gives out again, or they just can't go back immediately. Oftentimes, when they come into clinic, if they come in to see you, they may be walking okay. That doesn't mean that they didn't tear their ACL. You can walk with an ACL tear. You can even oftentimes do linear things like bike and jog once the swelling settles down and the motion comes back. So just because it feels okay doesn't mean that they didn't have an ACL tear. All right, just to wake you guys up a little bit. So this is the kind of most common mechanism of an ACL tear. The foot plants, knee collapses in. It's most common in soccer. This is a gymnast. This one's kind of worse because they have this tendency to land in hyperextension to look good. So if you don't land perfectly, bad things can happen. So, and just slow-mo, just to wake you guys up. I have so many of these. I can just change them every year if I wanted to. Okay. All right. So on exam, we'll get onto this in the hands-on session and the knee exam live, but patient has, you notice that anterior tibial translation when you're doing the Lockmans. They may have some posterolateral tenderness or achiness that they complain to you about. That's oftentimes from the bone bruises. So if someone says their knee twisted, kind of gave out on them, felt a pop, and they have some achiness on the posterolateral side of the knee, that's a little bit of a red flag. I hear that a lot when someone has an acute ACL. Positive Lockmans, pivot shift test, hard to do in the office even for us because people guard a lot when you do it. I'll show you what a positive pivot shift is. You want to check the other ligaments also, so that's why you want to go on to hands-on session and watch the knee exam live next. So pivot shift, boom. The IT band normally kind of holds the tibia in the correct alignment when the ACL is intact. The tibia and the femur are in their normal alignment, but when the ACL is torn, tibia sits a little forward and you bend the knee up to about 30 degrees. The iliotibial band will tighten and make the knee shift back to the normal orientation. So I'm going to re-show these in the next session too, so you can see that again. Radiographs oftentimes aren't very helpful. Sometimes you may see a small fleck of bone off the lateral side of the tibia. A lot of times even the radiologist misses this. This is like pathognomonic for an ACL tear. It's called a Sagan fracture. You also want to check, make sure there's no fibula fracture up in here because that means that maybe the posterolateral corner has avulsed, and that needs to be treated right away and repaired. On an MRI, you're going to see classic findings, no ACL, or just some squishy stuff. And the classic bone bruise, or what we call the kissing lesions. We think when the ACL tears, the lateral femoral condyle actually rotates and hits against the posterolateral tibia, so it's almost like the knee dislocates. These bend and smack against each other, and you get these classic bone bruises, and then the knee goes back to its normal position. But that MRI, if you look at an MRI and you see those bone bruises before you even see the ACL, you know you're going to see an ACL tear. So treatment options: low demand patients that don't do cutting pivoting sports and have no intention of. You can do PT, and they can wear an ACL functional brace for things that are like hiking, even sometimes skiing, walking on unstable ground. These braces really don't work great, though, for kind of hardcore cutting pivoting activities like football and basketball and soccer. So we usually recommend for those types of activities, or people that have very high demand jobs that need to have a stable knee, that they undergo surgery for ACL reconstruction. We may need to do surgery acutely if people have a bony avulsion or some sort of other ligament injury that needs to be repaired right away, except for medial collateral ligament injuries. We usually brace those. But generally, we wait for motion to come back and get the swelling down before we do surgery on patients with ACL tears. All right, last example, case number 5. A 21-year-old football linebacker is hit on the outside of his leg at the level of his knee by an opposing player. He feels his knee collapse inward at the moment of impact and a tearing sensation in the inner part of his knee. He's assisted to the sideline by the trainer, athletic trainer. Sorry, guys, I know you hate that. And is unable to return to the game. His knee swells up a great amount after the injury and mostly over the inner part of the knee. The most likely diagnosis is MCL tear. Good. This could be a meniscus tear, very similar mechanism. Could be an MCL and an ACL. This is the reason why clipping is outlawed in football, is people would get an MCL and an ACL tear, but we didn't put those up as options. So, all right. So MCL injury, Larry Fitzgerald getting hit on the outside of his knee. Medial collateral ligament goes from the medial femoral condyle down to the tibia. If you get hit from the outside of the knee, it can sprain it anywhere along here. Most commonly, the sprain happens on the femoral side, which is good because those are the ones that tend to heal but make people stiff. The tibial side guys are kind of bad customers because they tend not to heal very well. Sometimes we have to actually do surgery on those. Fortunately, most are femoral, and we can just brace people and get them to heal. So MCL sprains, most common of the knee ligament injuries, oftentimes hit on the outside of the knee, or a twisting injury like with skiing. May be associated, as I said, like with an ACL tear, or even sometimes a medial meniscus tear. Sometimes they can have associated injuries such as a bad bone bruise on the lateral side, or even a lateral meniscus tear. So if people don't get better after rehab and bracing, sometimes I will order an MRI down the road. Patients will have medial side of pain. They have pain when their foot gets caught in the covers, but they don't usually have pain with a deep squat or a Thessaly's or McMurray's. So that's how you can differentiate between them, and also the mechanism of how they were injured. Swelling usually isn't common in the knee, maybe just over the MCL. So use all these tools that you're going to get with the physical exam to figure out whether it's an MCL or a meniscus tear on the medial side. So MCL injury, normal medial collateral ligaments, jet black and thick. The meniscus is attached underneath. This one is torn on the femoral side. Squiggly in orthopedics on an MRI is not good. So it's all right. Exam-wise, and you'll learn this in the small group sessions and in the second when we go over everything. You want to apply a valgus stress to the knee and pull the ankle out laterally. And you look at the medial joint line, ask the patient if they have pain. You're looking for opening of the joint space. And also if the patient has pain. Usually grade 1, the patient just has pain and there's no opening. Grade 2, there's a little gapping. And grade 3, you feel like you can run out of the room with the leg. It's kind of gross actually feeling. So just to demonstrate that point, that's a grade 3 there. See the dimpling on the medial side? And this guy has a grade 3. You see, you can run out of the room with the ankle. It's a really acute V angle. So, All right, so treatment for these depends on the degree of injury. Grade 1, oftentimes we do a neoprene sleeve, do PT. Recovery 2 to 6 weeks, depending. These patients tend to, the lower the grade, the more stiffness people have, interestingly. So these ones may stay stiff and uncomfortable for a while. People oftentimes get tight in flexion and extension. Grade 2, we brace, oftentimes a shorter hinge knee brace. It needs to be a stiff brace that's going to allow that MCL to heal, usually for 6 weeks, and also do PT. A grade 3 injury, sometimes I'll order an MRI because this type of injury, there's sometimes a big bone bruise on the lateral side, sometimes a meniscus tear. So I may do an MRI when it's a grade 3 injury. So if you feel sick when you do the valgus stress test, maybe think about ordering an MRI. They may take a good 6 to 8 weeks to heal. The brace is locked straight, and it's a long hinge knee brace. You really got to control that MCL, and you have to make sure the patient wears it when they're sleeping because they cheat, and then they undo all the good of the day wearing the brace if they roll over on their side. Crutches, oftentimes for 6 weeks in physical therapy. If the MCL is trapped in the joint or there's a tibial avulsion, sometimes these need to be treated operatively. So the grade 3s you probably should definitely, that's good. They probably should refer to us to make sure that there's nothing that needs to be done acutely. Lately I've had a couple of football players that have torn their MCL off the tibial side, and the MCL was never going to heal down to the bone because it was like flipped over some soft tissue, and it wasn't going to heal without surgical treatment. Okay, that's foo. All right.